Good afternoon, everyone. Thank you for coming. I want to welcome you all to our art and medicine event. This is a HEAL event and continues our mission to align the work of artist patients with the core medical school curriculum and to foster enhanced understanding between patients and future health professionals. And I'm delighted to welcome Dr. David Chang, who is going to be our clinician discussant. And Dr. Chang is a spine physiatrist, and he's board certified in pain medicine, and he is a clinical assistant professor in the Department of Neurosurgery, and he's also in charge of the students' musculoskeletal system that they are studying currently. And Ted Meyer is our artist in residence, and I'm going to let him introduce our artist, or artists, I should say, and let you take it away.
Thank you all for coming. We're really excited to be back here in the auditorium. And we're just happy to be in person. We're all smiling, even though you can't tell. Dena Novak, someone had introduced me to her a while ago because they know I'm always curating art shows by patient artists, and her work is downstairs if you haven't had a chance to go down there yet. And we're going to talk about her work and her illness, which she will talk about in a second. We're going to start with a couple facts. Okay, so you have Ehlers-Danlos. Is that how it's pronounced?
It's Ehlers-Danlos Syndrome.
Okay.
Like
Look.
Ehlers.
All right. So I find this illness really interesting because you always think of the body as sort of like a set shape. You don't think of it as something that changes, slips around, moves around. So I've always found this illness sort of, I hate to say interesting, but it's someone seeing it's sort of interesting. And I have a bunch of, a list here that the doctor will talk about in a bit of different side effects, different symptoms. Now, for you guys who are med students and want to be studying this or possibly go into this field, between 1 and 3,500 to 5,000 people, or about 400,000 people in the United States has this, so you will be able to find patients for all your studies and all your, to come to your office and give them help. So we're going to start with the doctor here. This is her spine, so maybe you can take a look at this. I know you can't give a diagnosis looking at one MRI. But what are you seeing here? If she came into you with some symptoms and you did an MRI, what are you seeing here?
Well, first things first. I'm a spine physiatrist. I specialize in non-operative and rehabilitation for patients with neck and low back pain. So looking at this imaging versus some of those previous slides, this is much more familiar to me. This is a neck MRI, a sagittal view, a side view of the neck. And so the neck, as you know, is, for the students, is also known as the cervical spine. The neck looks pretty good. This is, you can see that the bony segments are numbered, and C1 is a little higher up. The segments are numbered, go from C2 to C7. There's several things that we look for on a neck MRI. First thing is the alignment of bones, and the way that I would assess this is looking at the back where the right-sided borders of each bony segment. Alignment looks normal. The second thing is I look at the integrity of the bones. And things I'm looking for are asymmetric changes in height of the bony segments. They usually look like a square. I'm looking for asymmetry of the top and bottom borders of bone. In general, the bones look really good. There are some disc bulges, particularly between the segment C5 and C6. Immediately to the right of that, there is a channel that runs up and down called the spinal canal. The white material is spinal fluid, and immediately to the right of that is the spinal cord. It looks like there is normal spinal fluid flow and no compression of the spinal cord. There is mild loss of curvature in the neck, and that can come from muscle spasms. But overall, the neck MRI looks really good.
that align with what you've heard before?
So what the doctor at Kaiser said, that there was some stuff going on at the C6, C5 and C6, and that was affecting why my right arm is going numb a lot. Like from basically like even sitting here. So it's in the C-spine, the
Okay.
lower part, they said.
Yeah, so we are looking at kind of one slice of the images here. I agree that on the side view between the fifth and the sixth bone, the spacer there, otherwise known as a disc, looks different than the other levels. We also know that disc bulges and disc herniations can happen even in the absence of trauma, and it can oftentimes be asymptomatic too. So I think in hearing that you're having some neck-related symptoms and some associated discomfort in the right arm going down to the hand, the next thing I would look for is a different view of the neck. So we're seeing the spine in this orientation. The next thing that we'll look for is particularly between the C5 and C6 segment, a transverse cut like so. And so this allows us to see whether there is any compression of the spinal nerves that go to the right side. This is a good picture for us to see if there is any crowding or in the center. But we know that there is no compression of the spinal cord, and you know that because there's plenty of fluid, the white material that you see on the screen, to the left and to the right of that. But this is an inadequate picture, so we would need a cross-section.
Well, they didn't do that, so that was my I had asked them, so that's what I'm trying to get, is a cross-section done. Because I agree with you, from what they have, they just called it cervical myelophasia and a bunch of different like structural like. So, and then they've been doing some shots, like some steroid shots.
Okay. Yeah, so I think that would be the next logical step. You know, this is clearly the way that you're describing your symptoms sounds like there could be a relationship between your neck and arm. And we are looking to see if between the fifth and the sixth level there is compression. If there is a compression of the spinal nerves that exit at that level, it would, just like you said, affect the C6 nerve. And that typically goes in the arm, shoulder to the thumb. So there is some overlap in terms of what you're describing.
Yeah, I'm feeling that exactly. It's in the arm and then in the thumb. And yeah, sometimes it even goes a little on my leg.
Okay.
So this goes right into the loss of movement in your arm from this. So let's talk about this. This is one of your paintings. You said this was about 5 years ago.
It's more like 6 or 7, but around.
Okay, so you were doing much more realistic stuff. You were doing paintings that were tighter, really were not relating to your illness at all. And then here's a most recent painting compared to your old one. So let's talk about how the illness affect your art, the technique, your imagery, and what about the illness made you switch styles?
Well, I think this is a great point. I think first I want to talk about that getting actually care with this disease is actually a bit of a struggle. Oftentimes I will come to the doctors with a recommendation and I'm told no, but they don't have all the material information to actually treat the illness. So because that's so difficult to get, even a standing MRI, Kaiser doesn't even have it, they'd have to send me to UCLA. It's difficult to get the whole picture, and I think like what you alluded to, without the whole picture, it's really hard to treat. That being said, there's been a big change in my OT skills from 7 years ago to today. My hand shakes all the time, I drop things.
Hold the mic up.
I'm sorry. There's been a big change in my OT skills. When I call OT, I mean fine motor skills. It's difficult to draw like a straight line that doesn't shake. And there's a constant kind of the back and forth of this. It often feels like my hands are attached to my neck, like there's nothing in between, and it's just pulling on it. And that's just the part that's dealing with the joints. The thumb subluxation, like as I'm, just even an oil painting tube, it's incredibly dense, the more material in it. I'm finding I've had to really alter the way I paint. I can't paint in kind of a realistic sort of style, and so in a way it's been incredibly opening because I've gone really abstract from it, but it's still not really dealing with the issues going on with my hands and my neck.
I think I see a lot in practice. This is those of us that treat patients with neck and back problems. You can have problems in other areas too, and especially for patients where the condition that they are having doesn't exclusively present as a neck or low back problem, where the symptoms are much more diffuse, where the check boxes in terms of the symptoms are more scattered, where it affects more than one organ system. I think this is where identification of the underlying problem can be so challenging. Anytime I'm seeing a patient with a connective tissue disease, that's one of the first questions I ask is that, how long have you had this? And frequently, they have gone through years without a true diagnosis. And this is what I try to stress to students, and having a session like this where we get to talk to someone like yourself, a patient with this medical condition for some time, and hearing about your experiences, not only as an artist, but as a patient, is eye-opening, right? It's just, medicine sometimes can feel so rushed, everybody's so focused and so specialized that we don't always take the time or the effort to tie everything together. And I think it's particularly for a condition like what we're talking about today, that's really key.
So let's look at these two paintings, both of you guys, actually.
I can see those, right? I'm looking
Yeah,
at
it's the same one.
Yeah.
So not only did your style change, but the whole, like you could have tried doing work about your hands and sort of abstracted hands, but you've sort of gone completely abstract. But when you talk to me about them, and we'll go through some of the slides, they very directly relate to your illness. So there was also a major thought process change as your illness came on, from doing realism to doing an abstract representation of what's going on with you. And was that conscious, or did you?
No, I mean, the paintings you're looking at are about, like, I work in series. I work in a hyper-focused way. I think that's part of my neurodivergence, because EDS is linked now with dysautonomia, which I suffer from greatly, and neurodivergent, i.e. adult autism, Asperger's, and for me at least, the idea of, I was always able to go into the idea, if I made a series of paintings, they would be whatever I set my head off. These were like a French Asian style that had to do with kind of like still lifes. For me, that was really meaningful, but when I started to lose the mobility in my hands, and I spent more time trying to make a straight line, I realized I was missing the boat. I was looking at art in a way of that I dictate to the art what it is, but in reality, it dictates through me how I create. And the art was saying to me, literally, you need to be very immediate. Instead of thought out still lifes that are conceptual, it was very much about, I would put a mark on the canvas and I would react to it intuitively. And that experience of making it, taking it out of art school, taking it out of my graduate program, instead of trying to be a great painter, I was much more focused on reacting to the marks. And that actually freed me up, I think, to become a better painter than I actually was. I think I had to go through the process, and my training is in the marks. But in terms of how it develops, I think many figurative artists go more abstract as they get older, but I think my body was just pushing me to do it, and I was responding to, the art comes from me, so I have to respond to it.
So do you find that your patients that aren't artists have to adapt too as they, or is this a unique situation that you're seeing here?
I think that's true. I think that for you, your journey is unique in that looking at your paintings throughout the years, you can probably recall and perhaps even place yourself in that time of your life and your journey in terms of how your dexterity has changed over time. But I think that's a lot of patients undergo similar frustrations in terms of coming to a diagnosis and then moving forward, learning how to adapt to their new normal. And that new normal is evolving and it's ever changing. You have good days and bad days, and I'm sure that's manifest in your art.
Right, so why don't you talk about this one a little bit? So how does this relate to what's going on with you? And move the mic up just a little bit.
This one makes me laugh because it's a painting people always love, and it's called "I'm So Pretty, My Genetic Miscommunication." And I find this one, from the outside, everybody is like, oh, you look so good. And it's a very limited understanding of what it is to be even sitting in a chair for me. Like, as I sit here, my hands are going numb. I feel the blood pressure changing in my feet and dysautonomia, which makes me want to sit like a kid, like this. Right?
You're allowed to.
You're free to.
Because this is what's going to stabilize my joints, that's going to allow me not to have a blood pressure drop while I'm talking to you and make me comfortable. But this is a kind of funny way for an adult woman to sit. So the issue of being uncomfortable is present all the time for me, whether it's temperature-wise, my autonomic system doesn't relate, so I'm overheating outside there wondering, clothing-wise to temperatures to then just uncomfortable numbing and joint pain, and that's not including picking up a gallon of milk. So all of those things have an effect on my day-to-day life, and like you said, it's more of like a new normal. Sometimes I fight it a little bit, though.
This is a common challenge for patients that have what I like to call invisible disability, in that sometimes doctors or clinicians will see you and you look structurally, physically okay, meaning that you're not agonizing in pain. And we use imaging findings as surrogates to how you're feeling, how we measure how bad a problem is. But when a problem is not always obvious on imaging, then you get labeled sometimes, that things look okay and there's a clear distinction between how abnormal your imaging is versus how you're feeling. And that's a shared and very common history that I get from patients with EHS.
So is this a genetic illness that has like one mutation to it because it's got so many different, in her case, it's so many different symptoms?
I think there is definitely a genetic component.
Mine's the COL-A1A gene. So it's the COL-A1A, so it's in the type 1 protein.
Yeah, the IEM, I think historically this has been viewed as a genetic disorder, but there are also patients that have no family history of this whatsoever. I think the fact that there are so many different types of variants and subtypes tells us that we need to be even more open to consider the constellation of symptoms before having a very strict kind of check-off diagnostic criteria for patients in this class of medical condition.
So speaking of other symptoms, you sent me this photo yesterday. So
that's what it's like after I'm done painting. So the heat makes me throw up. So pretty much after I'm done painting, every time I throw up, because the standing, the heat, just the temperature, it could be the oil smells, even without turpentine or turpentol. It kind of like, oftentimes that's how I'm left. And I kind of put that up there because people don't really see that part.
So is it
It's the throwing. I mean, it's just, you can explain dysautonomia. So it's the autonomic system. It's not registering temperatures. And
Essentially, it's the body's way of
I'm going to have both you guys keep the mic.
it's the
near your
body's way
mouth.
of regulating blood pressure and heart rate. And so when that system is affected, if that blood pressure gets low or your heart rate gets low, you can develop some dizziness, extreme fatigue, and so it can come on in the presence of something that is noxious or painful, or something that is physically strenuous.
So what symptoms first brought you to the doctor, and what symptoms do you normally first see when someone comes into you and they don't know what they've got?
I think it was, for me, it's my daughter Panina. I was on a discovery for trying to figure out what was going on with her. And we went to Children's Hospital, and finally there was a geneticist, and he said, I think you guys might have, a connective tissue. And he looked at both of our eyes, and there was some blue on it, and that was this blue sclera that kind of, he said, we need to do some testing. And so when we did the testing, I was the carrier of EDS, and they showed the gene that was faulty. And that's how we found out about it. And then as she was kind of going through the process, I was really realizing a lot of that was what I was dealing with. And that was clarifying for me. And then I went to a geneticist at Kaiser, and they then diagnosed me with the Beighton scale, and also with her. And there was already, they found the deletion in the.
So what's usually the first symptom that someone shows up in your office with?
Well, really by trade, patients come to see me if they have neck and back pain. But that said, I think that the classic patient who comes in would describe multiple joint-related injuries, dislocations, subluxations, as you said, and also a constellation of symptoms that don't necessarily fit strictly under the musculoskeletal system. It's not necessarily just a bone pain or joint pain. It's that things just feel loose, or things feel really tight, or that small physical activities, things that you really wouldn't think about, such as picking up a gallon of milk, really becomes a much bigger ordeal. And it's someone that has a long history of these symptoms that no one can seem to figure out, and oftentimes kind of dismissed by specialists. Those are the things I'm looking for.
All right, so let's look at this painting and talk about how does this fit into your symptoms and what's going on with you.
This painting is the DNA of the landscape of my DNA. And I like to think of it as an exploration into DNA and a meditation on what that means, because like you pinpointed, it's many layers to get diagnosed. And when you are someone, for me, the diagnosis really dovetailed with my daughter. And that's a lot of layers to have gone through. There's a lot of questioning. Why do you want a diagnosis? What do you even the geneticist said to me, well, what is getting a diagnosis going to do for you when there's no treatment? And I'm like, well, it makes me not crazy, because it's really difficult when your whole life you're just the person who has the aches and pains, your body's falling apart, you're throwing up in the car, you're this, and you're just the problem. It's really, I think of it as a victim disease in a lot of ways, because it's primarily women is primarily negated until there's certain things they can see, or you have a child, or you get lucky enough like me to get a genetic test that comes back and tells you what you have. In a lot of ways, I've had a lot of privileges with our American care system, in that I've gotten this, but at the same time I'm still reaching a place where I have no answers except through my art. It's the way I cope with it, because there is nothing really set up, like you said, holistically, at least that I have found, that's dealing with it. So I'm using my art as a way of dealing with it.
All right. Talk about these two.
Well, I think that I just wanted to talk about, I started to do this series by doing a lot of meditations on my body, and I started to think about what it would be like if I were to look at neurodivergence and look at different ways of processing information. And one of the things that's really great about being different and neurodivergent and unique is that I have certain skills that I can every day hyper-focus for 8 hours a day and continually do the same thing and paint till I achieve what I want. That's a really big benefit. The problem is balancing that now with my body. And my body really can't take 8 hours every day. It might want to take 3 hours. So there's that balance. For me, the art became literally a way of coping with the disappearance of my body. So the paintings, if you go downstairs, they got thicker and thicker. I don't know if you got to see them, but Lancet of my DNA is almost like this thick. And someone said to me, you're creating a body of work, and the idea of body, it was literally like as dysautonomia was carving away with the nausea and weight loss and heat and throwing up, I was putting it back on the painting in this like kind of frenetic, also desperate way to like create a body of work that stands beyond me and stands beyond my limitations.
Tell us a little bit about in the very beginning when you went into the doctors to seek care initially for your daughter, what type of symptoms you were having at that time, and kind of how your condition has evolved since then?
Yeah, so it's always been like a lot of neck pain and joint pain, and it was in my fingers. And those were all kind of like, my fingers were never affected before. I always had like very powerful OT skills. I could like, very crafty. And so for me, it was just starting to show up in like a lot of like dislocations, realizing that like things were moving and they shouldn't be, or sleeping on my shoulder and the next morning it's like kind of out of its socket. And it became kind of like, I went to the doctors and, you know, the answer was, they would take like one x-ray of my toe and they would say that has arthritis and your bones, you know, have osteopenia. But everything, if you take it outside of context, can be very benign. But if you don't put it in context as a whole, it also doesn't have a solution.
And in terms of the doctors who have seen you for the neck pains and some of the hand or OT fine motor skills, what type of doctors have you seen during this time, and how long did it take for your condition to be kind of recognized and diagnosed?
Not that long,
okay.
Because we did first of all, I was like at 50, I was a 9 out of 9 on the Beighton scale, so that was kind of easy. Like my length of my arms is even longer than my body, so the gene that I have is a little bit, has some osteogenesis imperfecta, it has some Marfan's, so it's really kind of, and it has the EDS. It might be actually another EDS link, because they're constantly coming up with new ones, like you say. Yeah. It's definitely in the EDS category. And in terms of treatment, I've been seeing a pain specialist at Kaiser, and he's been really, you know, supportive. They can't get me in that often, but he's been doing different kind of shots. Yeah. And
do they work for you?
No. But I like the idea that he's like, there isn't, I mean, unless you're really going to put someone in PT, OT, and allow them to learn how to do it and then support their bodies through it, I don't really know how to get to the next point because the body's so broken down by this point.
All right, I put another one of your series up. So these are a couple years apart, and why don't you talk about what's going on with these?
So the piece is My Blue Sclera, because I kind of think about that day a lot. One of my friends was here who went with me, and Panina. My friend Gila is here, and she was there when the doctor looked at our whites of our eyes, and it was really shocking to me that that's like the bone coming through my eye, because the collagen is so thin that you see the blue in my eye. And as an artist, I was very interested in the color cerulean because it's a type of blue. And so the fact that that was the color that was showing through, you can see that there is a period of time where I was just using marks as a way of kind of, I would say, mark making, but it became something much more specific when I started to look at my body in relationship to it. I started to be able to build the layers of the paint as though I was rebuilding my body.
And what you had talked about the difference between these two and the time period.
Right. So in the first one, I mean, it was, again, that was when I was just kind of like, that would be an example of like someone just responding to paint and intentional painting for the second. Like you're just there, you don't know what you're doing, and you're just going to respond to the mark. There's a very like simplistic naivete to that painting that I think like as my understanding of the illness progressed and as my understanding of my body and working through it, I think the layers became more important and gestures become more important. The art's clearly changing because of the context.
So how do you feel as an artist? I mean, you know, and I bring this up almost every talk, that you're making work that would not have happened if you had been healthy. You might still be setting up still lives and doing those. Whereas these are really personal, they're really dynamic. I think they're much, much better paintings
I was going to say that.
than you were doing before.
Yeah, definitely illness has like done my art good. There's no doubt about it. Like I was a good painter, but I'm becoming great as a painter. Thanks. I mean, and that's really a unique experience to be like 54 and, you know, to be able to see that what you're doing has, you know, incredible value from a creative perspective and from a perspective of teaching people, from the perspective of not being a victim to an invisible illness, to being strong and powerful like my paintings. Yeah. That's my friend.
All right, let's talk about.
That painting's called Disjointed, and it's the name of the show. And the doctor was talking about, you know, I'd love to hear about your experience with other patients, because that's really what it feels like. You feel stretched out. You feel disjointed, like my legs are too long, like they don't fit, and they don't want to be down on the ground because it affects, you just don't realize, like, this affects my blood pressure. So try to go, I mean, luckily I did well in school. I liked it. But I probably sat like this my whole time, I'm pretty sure. I've been known, you know, if you see me grocery shopping, I'm so disjointed in terms of my discombobulation, kind of that adult Asperger's autism piece isn't so great when you're trying to grocery shop and you can't remember anything, but it's really great when you're hyper-focusing 8 hours a day. And this piece just kind of was, I decided at a certain point that it wasn't enough to just paint the paintings anymore. I started to carve away the oils with my clay tools. So then it started to become this kind of ritualistic exploration of not just layering, but now I'm carving back pieces and then re-putting them in. So it's like eviscerating it and pulling it back. And the act for me became very cathartic. It's not always about what it is for other people, but for me, it's very cathartic.
All right, and this is your daughter's work. So I want to talk to both you guys about this, because I am also somebody with a genetic disease, and I know my mom always felt a little uncomfortable that I had gotten something from her. So is genetics something you talk about? People, if somebody comes to you and they're of childbearing age, is this something that you think about? That your daughter has this also, and then we'll talk about then maybe you could talk a little bit about what you see in your daughter's work relating, because she also has the same illness.
Right, so I have, this disease has you can correct me but I think it's 50%. I have a 50% chance 1 out of every 2 kids of mine can have it. It's not 25%, but it's 50%. Is that correct?
I think you probably have a better handle on the numbers than I do.
Okay.
The numbers that I saw were kind of all over the place.
Okay.
This is where I think having sessions like this is really helpful, because I'm all the time learning from patients, and it's clear that, you know, this journey has made you an expert in the area, and so you probably know more about your condition, especially how it impacts you more than most of the physicians that you see.
So do you feel,
Wow.
do you feel more of a, do you think you have more of a kinship with your daughter because you're both dealing with this?
You know, I think we're either really close. She's also 19 and a teenager, so there's a little bit of like her becoming her own person, and then we're having a little bit, you know, I mean, she is an incredible person. Her art's inspiring, her depth. It hurts me when I see her physically in pain, and I see, you know, what I got to do. I got to hike mountains, because a lot of times for people, the EDS, and I've always been confused by this, but it came out for me more around my menopause, when I was about to go into it, and for my daughter around when she got her period, and so there was that kind of link. But beyond that, my understanding is EDS can like kind of appear. Like I kind of had like pieces of it, but at some point in my life, it just clicked in, and I kind of got more and more pieces, the dysautonomia. I don't know how to explain it. It's like a puzzle that's just getting put together.
It sounds like there is a pattern to your symptoms depending on the levels of your hormones. And that's so either menopause, menarche, or during menses, that there is a fluctuation of pain. I think I'm not an expert in connective tissue disease, but that certainly sounds like it's a plausible link. I do see that in my practice too.
So what do you see when you look at your daughter's work? Do you see things that when you were that age you might have painted, or at whatever point this disease really came on to you that she's dealing with?
I think it came on with her, and she was really impaired. It came on like quick, and more dislocations, because she dislocates her knee, and it started in her ankles, and I dislocate up high. So it's a lot more impacting when you're walking 2 blocks and your knee pops out than it does when you're able to walk. My shoulder doesn't pop out by walking, or my thumb. So we have really different experiences in terms of our ability to like be in the world. For Panina, it's been much more about her body, because it affected her knees really young. So it's more about like college, like we're looking at different colleges, and I have to think about like how far is the walk in the quad? How far is this? You know, I have to like constantly analyze walking, temperature for her. There's a lot to take in, and when you're as talented as her, I think what hurt me the most, the only thing that I really feel about is just her hands, that her joints in her hands dislocate more than mine. And as an artist, I switched her to the iPad to take the pressure off, because her OT skills, if you look at the painting of her heart, it's a drawing, and they're so tight and so precise, and she was putting so much pressure on that little tip. I tried to take the pressure off her fingers, but that's all I can do. And just like if she's an artist and wants to go around the path, then I'm here to help take her, but it's her path. Those are her pieces. One is both done on the iPad, and I think they illustrate. She's constantly drawing self-portraits, women, kind of bodies that are missing pieces without a head or one eye. So like her work has a disjointed quality, like you had said to it. If you look at the pieces, they're always missing something. So I think she was internalizing her, and I believe that Panina is using her art to like internalize her own experience with her body.
All right, so my last question, and then if anybody from the audience has anything to ask, I always ask our experts, how did you end up picking this as your specialty? What about it? What about it drew you in?
Yeah, so that's a really good question. My specialty is in physical medicine and rehab. I think much of medicine has been kind of focusing on diagnosing and curing or treating. And so physical medicine and rehab as a specialty aims to restore quality of life and rehabilitate patients, and kind of walk side by side with patients on their journey to adapt to the new normal. And I think that in looking at your pieces and listening to your story, there has been a lot of that. You know, that being recognized, being heard, and coming to a diagnosis is a critical part of my field, and being able to partake in this journey with you and with patients of mine with neck and back problems has been extremely valuable.
So, I always talk about how some specialties you end up following a patient for years and years. So do you have patients that, I know you just got here to USC about 2 years ago, but assuming you stay here for a long time, and we hope you do, are you going to have patients that you follow for the next 10, 20 years?
Yes, so this is, patient continuity is integral for my field. This is treating patients with neck and back pain. It's not a one and done scenario for lots of patients. It's addressing the now and also anticipating what's to come. I think that one thing that we keep hearing again and again today is that symptoms change, medical conditions can evolve, and as medical professionals, especially as we're learning more about a subject matter as complex as EHS or EDS, I'm sorry, I expect to follow patients for a long time.
Okay. Do you have any last questions for our?
I guess I do have a question. Like, if you were, like, what would be your first, how would you handle a patient? Like, is there any advice you would have to EDS patients at all you might want to share?
I think the very first thing is identify a subject matter expert. And I think having someone who specializes in connective tissue disease, specializes in rheumatology, that would be the first step. For a lot of patients, the hard part really comes well before that, meaning that the biggest problem is finding a diagnosis and making sense of the symptoms. After that, I think the management and treatment piece for most patients is much, I wouldn't say simpler. Well, it's simpler but not easier, but it's everything beforehand that is the most challenging. So we're lucky to be in Los Angeles. We're less lucky to be at USC, where there are a lot of experts around. And for patients that feel like they either feel dismissed or they're not being heard, it's probably because we've been looking in the wrong place. And so seeking a physician that is going to be able to address all the areas they have pain and try to put the pieces together, I think that's really critical.
Great. Dr. Schaaf, do you have any questions, or anybody from the audience?
I'll just ask first for any questions from the audience. There are mics in a microphone here, or you can just project your voice, because we're very...
I got one.
Yes.
Has your treatment team found your art to be therapeutic? How have they responded to your art?
My treatment team is Dr. Kalangia Kaiser. I have a year, I want to leave, but it's like he's really good, and he's been so supportive, and they love my art. He's tried to bought one of my daughters. I think they really enjoy my art on multiple levels. They enjoy it philosophically, and they like what I'm doing. And also, I think they're interested in art from an academic perspective, because I think there's a link between science and art in the way we look at the body, perhaps, in some sort of links. So I have found really great relationships with the small care team I have.
I want to thank you for coming. Unfortunately, I know that there's a group of students coming in for a lecture, so we don't have a lot of time, but I would encourage anyone who hasn't had a chance yet to browse the gallery downstairs to please visit. And Dena, thank you so much for sharing both your art and your story. And Dr. Chang, thank you for your insights.
Thank you, Keck.
Really appreciate it.
For the med students that are in here, I just really want to reiterate her point that in this case and in other cases, having an illness can really work out for you creatively.
Yeah.
And so when you're dealing with your patients, and this is why I'm here, their life experience in certain ways can be enhanced by an illness. Mine has, hers has.
True.
There's always, there's normally also a big downside, but for all your patients, sometimes there's an upside, and for your bedside manner, you can always ask them about that. Does the illness ever have an upside? Talk to them about the better points of it, not just always the bad points. And that's my speech for today. Thank you.